really set the pace. Especially in modern times. Well, I'll share that with you. I like your, is that a robe or what is it?
It's like a sweater.
So yeah, literally everything is already painted.
It's made out of pashmina, so that's why it looks like pashmina.
What's that?
It's like a type of fabric. I don't know how to explain it. It's a type of wool. Yeah, pashmina.
So type of wall.
Yeah, but people make a lot of like scarves out of that type of fabric. Yeah, it's very soft.
Oh, I thought. I always like because people are like, it's not a scarf, it's pashmina. So I thought it was like the type of scarf, but it's the type of material.
Oh.
See, some people are so bougie, they're just like, that's not what you call it.
Yeah, a lot of pashminas are made with like specific, because it's a specific wool in India. Yeah, like a specific type of sheet.
So it's the material, not the actual like garment.
Yeah.
Yeah. I always thought, I was like, oh, I don't know, maybe it's like a bigger scarf or something. But that, I mean,
It's a lot of questions. So
Wait, is it recording?
mentorship is my biggest thing. I have my own business, and so
Wait, I'm not.
continue here. So once I start, my goal is maybe graduate.
Wait, doesn't actually.
I think you're Asian, but I don't want to
if she comes to my house,
I want to have a
I come to your house.
Yes. So that's consultation.
Whoa, excuse me. No, that one was originally mine. You're gonna have to take that one. Sorry.
There's a lot of different things.
So I'm gonna jump in my grave that quick too? Serious?
So wisdom is, you can wisdom that.
I can't figure it out.
So
Yeah.
so definitely, yeah, so once we get everything going.
Oh, the
reach out to you.
Yeah, and yeah, and feel free to see me come up.
Yes, I will.
Were you able to get into?
Merry Christmas.
Bye-bye. Adios.
Okay. So, is the cat 2-1 holiday, you guys? We can do this one first.
hey, Jeannie wants a category.
Oh.
Actually,
Wait,
is everybody
I'm
back?
good.
It's gonna
I'm
be
coming
hard.
back around.
We'll be missing a few souls.
Missing a few people.
Well, we'll roll them here. I could go ahead and do this one first too, I don't mind.
Oh, that's all right. I'm good.
I wanted to do that one last.
I thought that was, yeah, I thought that's the one. Where'd it go?
So it makes for a long weekend, these 100-hour. Last year, we cut off about 2:30, I think.
Category 2.
Got to.
Yeah, but also wasn't enough time, I didn't think.
It wasn't, no, it was always only. Yeah, we'll go. Okay, so I keep mentioning category 2. I said, everybody's got category, I think a lot of them are gone right now. We're really thin. We wait a,
I would wait maybe, because those guys live across the street.
I'll
They
wait.
should be here.
a
Or
couple. They
anyone,
might,
anyone has their numbers, you could text
they're
them. or
probably
something.
thinking 1:30, which is fine. No, wait, we broke it a quarter after. Didn't we? Oh, wait a minute. We need a consortium, right? Do you have enough members showing up so you can take a vote?
Oh.
We have a consortium.
Yes.
Is SFSU San Francisco?
Yes.
San Francisco State U?
Mhm.
Is that right in San Francisco?
Yeah.
Are you
Wait.
from San Francisco?
No. No. I'm from Los Angeles.
LA.
Yeah.
Which part of LA? Like LA or?
No. Like San Diego Valley, Pasadena area.
Oh, okay, yeah.
Yeah.
I lived in the 70s, I lived in Orange County for a
Oh,
couple years.
really? Where in Orange County?
well, I lived in Orange for a few months, and then I moved down to the coast. I lived in Huntington Harbor with some friends on a yacht that some guy owned.
Oh, in the actual harbor?
Yeah. We rented the yacht. There was 3 of us, 4 of us actually. We lived in this yacht, on this yacht. And the guy was about to lose it. He was going through a divorce, and he had to like put it in somebody else's name, and we were just paying rent and had a place to crash and rent month to month. And finally, we had to move from there. And then we moved into a little cottage in a place called Surfside, which is just south of Seal Beach. And then and I lived in Sunset Beach for a while, and then I moved. I lived in Yorba Linda. So in 2 years, 2.5 years, I lived in like 8 places.
Yeah, you went like up and down the coast.
Yeah, the coast and then back inland. And I worked in Anaheim. That was a long time ago. It was a whole half a century. Actually, it was half a century.
How was it living on the yacht?
Oh, it was fun. We were just a bunch of stoners, you know, musicians. We were playing music and having a good time and trying to find work here and there. The yacht was fun, and it was really crowded, and this is kind of stupid, but hard to make deals. But we were like 19, 20, so
They didn't need much.
we didn't need much. And nothing was very permanent. Everything we did was sort of like, well, right now this is working. Eventually, though, I just before I turned 21, I decided I really need to go back to Oregon where I belong. I've never left. But it was fun living down there, except if I'd had any money, it would have been really fun. Went to a lot of concerts back in the day. Saw the Rolling Stones and the old LA Forum. Saw Pink Floyd, a bunch of Santana, The Dead. You know, so that's what I spent most of my money on. Concerts and food.
That sounds like a good time.
That was a good time. But it wasn't to last.
Yeah.
Not a sustainable life. I knew I was going to have to grow up eventually.
I was 21's pretty early to realize that. Well, at least you went back.
Well, I'm not saying I grew up. I started the process.
Got it.
Yeah.
Remove yourself from
It
it.
took another 30 years to grow up. Actually, it's probably still going on.
Frontal lobe development still.
So,
These are your star students here.
Yeah, I would say.
you're the best.
You get extra credit.
I should teach all you guys stuff, teach you guys the good stuff.
Well, we can't guarantee they'll come back. Well, I guess their stuff is here. They could just not come back.
Well, Elle's still here. There's your gear.
She's
Well, Elle's
helping.
doing it right now.
She's cleaning up.
Oh, look at you. So that's what the presidents do. They do all the stuff nobody else wants to do. I'm the CEO. I have a corporation, professional corporation. I'm the CEO and president. I'm the guy that vacuums the floor if my office manager doesn't do it.
Oh, wow.
So it's like whoopsie doo.
Keeping you grounded.
Well, it's just every year I have to, do you have a PC? Every year I have to file a little report to the state status. So I technically have, my old bookkeeper used to make something up about my board meeting, because supposedly I'm supposed to have a board meeting, and there's supposed to be minutes.
Oh, because you're
Technically,
CEO.
Well,
Do
if
you have a corporation?
If you have a corporation.
Oh, yeah.
And if the state really wanted, they could probably come in and say, we need to see the records of the corporate.
Well, that's what like Howie and George Gonzalez and all them do.
Yeah.
They like have their CEO meeting in someone's lake house for the weekend. record the minutes.
I can imagine.
Tax runoff.
Yeah.
Imagine what those meetings.
They do work on each other, I'm sure, and discuss
I'm sure they
business
have
at some point.
a good time. So, we're gonna talk about category 2. So, category 1, category 2, category 3, all comes from SOT. State law. Sorry. It comes from the old osteopathic work from the 20s and 30s. Desjardins, yesterday I think I mentioned Desjardins, Dr. Desjardins was an osteopath who took all the osteopathic cranial work and kind of really put it into a sort of a specialty and taught it for many years. And so there was kind of like George Goodhart put a whole lot of things together. Oh, is that the child? Oh, you did see it first.
Thank you.
So Desjardins came up with the pelvic categories. There's category 1, category 2, category 3. They're not a degree of severity like hurricanes. They are just a different kind of pelvic dysfunction. Category 2 we introduce first, and then Cat 1, and then Cat 3. Because Cat 2 is the most common and easiest to learn. Basically, category 2 is a sacroiliac misalignment or subluxation. So in your, the people who teach you guys phys med or adjusting or whatever probably talk about PI iliums or talk about SI fixations or things like that. This is basically a category 2. The thing is that in AK, what we look at is we look at there'll be a sacroiliac misalignment or dysfunction, but there's another package of things that go. So when a pelvis torques and this side gets subluxated, it's going to affect all kinds of things besides just the pelvis. It throws everything into an altered state. So you can adjust that fixation and get it moving again, but it doesn't necessarily clear the other factors. Now, the way we go about it, okay, so before Dr. Goodhart created these protocols, Dr. Desjardins addressed category 2, category 1 with his craniosacral techniques. Dr. Goodhart put the muscle test in. So he started to correlate which muscles would tend to be inhibited on which side and what findings you would find with therapy localization and challenge. So Dr. Goodhart took it further. So he didn't come up with these categories. He brought it into AK, gave it an AK protocol. So the way we find, and this is nice, kind of a nice clean approach because the way you find a Cat 2, category 2, is one-handed TL over the SI. Testing a strong indicator muscle for you. Now, you might also find one-handed TL over the lesion side will cause certain muscles to facilitate it. So it can work either way. And like I always tell people, if you find something that turns on the weak muscle, TL or challenge, then go to find a muscle that isn't weak in the clear. See if that weakens, because that's your double verification. And that helps you dial into how you're going to treat it. I don't get hung up too much on this breath in, breath out stuff. Unless you're going to do side, most of these we're going to clear with blocks. We're going to use blocking, and if we don't have a block, we have one set of blocks. Maybe we have more than that. Anybody do blocks?
Shoes.
Shoes. We use shoes. So shoes work really well. Everybody's got shoes laying around somewhere. So let me have somebody. I've told several of you have a Cat 2. Anybody who I've told have a Cat 2 or knows they have a Cat 2, please come forward. One of you.
Go for it. I'm getting that. Quicker first. Go for it.
I love trying. You had, in ocular lock, you had an occiput, a C2, is that right? We corrected it with respiratory correction. So, but then we kept going back and you still had a positive TL here. Now, just to clarify, if you are taking notes, between category 1, 2, and 3, category 2 is a subluxation of one SI. Category 1 is an overall torsion of the pelvis, and it involves the whole pelvis up into the occiput, certainly up into the upper. Category 3 is a subluxation between the L5 and the sacrum. Basically, it's a disrelationship between L5 and the sacrum. So just keep that. We'll go into those later. Not today, but this weekend. But the confusing thing, and I'll say this many times till you totally get it. The therapy localization for category 2 is one-handed. The therapy localization for category 1 is two-handed. The therapy localization for category 3 is there is none. You have to challenge. You have to go straight to challenge. So remember that for your test. And I'll say it over and over again. But category 2 will show up with a one-handed TL. Category 1 will show up with a two-handed TL. Now, Dr. Goodhart, the category 1, 2, and 3 was already established. He found that category 2 only responded to a one-handed TL. So that's how we ended up. So it wasn't by design. So push in and push in. Those both seem pretty good. Just kind of looking for several different strong indicator muscles. Good. Now, I want to double check the ocular lock before. There. Eyes up to the left. Seem to stay, right? Good. Eyes straight to the right. So that's, she's held that so far. Can you touch your left SI? Was your left or your right? So just easy peasy. Just now we'll do the same here. We'll check it here. Yeah. Now, any muscle, because TL over a subluxation, any muscle in the body will test weak. So we didn't pre-test it, but everything I test will test weak if she's TLing now. Now, sometimes they're not quite, this is a beautiful, clear example. Sometimes they're not quite there. So that's the first stay there, okay? So that's the first thing that happens. We TL it and go, we think we have a, oh no, so, TL again. Take a breath in, hold your breath. So it's negated by a breath in, so that's a PIEX, which is the most common. And that doesn't matter so much if you're going to block it. If you're going to side posture it, you need to know if it's an EX or an IN. EX means it goes PI and the innominate flares out externally. That's more common. If it goes PI and it flares internally, there's often more severe injury going on. They're quite rare. PI-IN is quite rare. AS, which is the opposite, that's where the pelvis, you look up here. So here's the PSIS, that's our reference point. So if this comes back towards us, that's a PI on this side. If it goes forward and the ischium comes back, that's an AS, that's an anterior superior. Comes back, it's a posterior inferior. So it's the PSIS is the reference. PI, posterior inferior, or AS, anterior superior. PIs and ASs, I find them all day long. And a lot of times you'll have a PI on one side and AS on the other, but one will actually be a subluxation, the other is just sort of compensation. And it won't TL. So by contrast, now TL both sides. That's for category 1. She doesn't have it. Take that hand away. I'm not sorry. Yeah, take that hand away and just do that. So the right side doesn't TL. Left side TLs. So now, who's laying back? You you can TL someone in any position. And, but then once you get ready to treat the pelvic dysfunction, you can have them on, you can have them supine. You treat, you block a category 2 supine. You block a category 1, block a category 3. So now, we determined it was the left side. Is it a PI or is it an AS? Here's how you know. Usually the PI side, there'll be a short leg. Leg will be not anatomically short, but functionally short. And hers is just a tiny bit short on the left side. You don't have an anatomical leg that you know of. That's one piece of information. Then you find a strong indicator muscle. This came out of SOT, and I prefer to use a TMC, but in the classic SOT, they used what they used to call an anterior deltoid test, which really isn't a real muscle test. It's sort of it's a muscle test, but it's not a specific muscle. A lot of people use this for cranials, these are for nutrition, all kinds of stuff, but it's not you're not really testing the anterior deltoid. There's a much better test for the anterior deltoid, but that's what they used to call it. So some people still cling to that terminology. Now, this is one place where Dr. TL, we were just perfectly fine with it. If you look at her inguinal area, a PI will TL in the upper part of the fossa. AS will TL at the lower part of the fossa. This fossa is formed by the So it's the upper fossa, short leg, and then there'll be tenderness at the medial knee. Okay. Now, not too bad there. Sometimes both knees. So she has all three. Those are the three. So Dr. I think it was Dr. Goodhart that came up with this. Because when the pelvis is this way, there's a slight tethering on the sartorius. And there's so the sartorius will often either it can test weak or it can test hypertonic, but it has an effect on its attachment point. Now, an AS, it will be lower fossa, lateral knee, and it'll be the long leg. So you remember UMS, upper fossa, medial knee tenderness, short leg, UMS, for a PI. For an AS pelvis, it'd be LLL, lower fossa, lateral knee, long leg. That's how you know. And then, of course, so if you have a positive TL, you don't know if it's a PI or an AS yet. You know it's a category 2 probably, but you don't know. So the way you determine PI, AS are those three pieces. I have that on. Now, I jumped ahead of myself here a little bit. Here's the postural presentation for category 2. Remember from last session, we looked at each other and we looked for things like this, we looked for things like this, we looked for things like this. So here's the three postures you want to think about when you think about categories. Category 2, head, as this stick figure shows, head and gluteal crease will be, head and feet will be on the plumb line, gluteal crease will be off, and the shoulders should be pretty level. But there'll be this kind of shift like this. That's a category 2. Category 1, the head and the back of the head, the EOP and the gluteal crease will be on the plumb line, but the body will be torsioned like this. That's a category 1. Category 3, you have the gluteal crease and the feet are on the plumb line, and the head is off to one side. That's a classic category 3. So when you're looking, even if you haven't mastered any of that stuff yet, when you look at your patients or your people you're working on and you see those three kinds of one of those three kinds of configurations, start thinking about that stuff. But the first one is category 2 is like this. And it's usually the PI side that's off this way, but don't count on that.
What do you mean they are shifting back and forth?
When they go into a resting static posture, there'll be distortion. Because there'll be a lot of muscle imbalance. And then of course the category 1 is a whole different thing. That's a true go to work kind of problem. So lateral sway and standing position capture. First rib head tenderness. So, not always.
Why would it be tender?
What's that?
Why?
Because when you're doing this, there's going to be some torsion up here and compensate for that. So you can see here, this is the upper fossa, lower fossa, AS lower fossa, upper fossa PI. Medial knee tenderness. This is for a PI. UMS. LLL. This is the AS side. She's got a PI. She fits the UMS perfectly. Don't worry about this right now. Worry about this right now. Let's just nail the basic cat 2 and then we'll get fancy. Okay. So how do we treat it? Now, the nice thing about if there is rib head tenderness, which Dean, you might have had this might have been a good thing. We already fixed your first rib, so too late now. But if they do have first rib tenderness, that's a good thing to monitor while you're blocking. That's not tender. Okay. I won't make it tender. So we go back here, this kind of classic SOT. Now I take it one more step and I will challenge the innominate back. And I'm doing a static challenge further in the lesion. Go forward, strong. I push it back. So I'm finding 16 ways to prove that it's a PI. I go to this side, nothing happens. Now, if I go down to the lower, no, that doesn't happen. So we're going to block you. Bring this arm up here. And just under there.
Blocking
Well, those are
90 degrees.
the block comes in 90 degrees on the PI side. Block comes in about 45 degrees under the ischium on the other side. So it's like this. There's we have this. See if we can find a slide that has the blocking. Come on. There we go. So, and that's actually exactly what we. There's the straight in and at an angle. Now, these don't take long to clear. If they don't clear fairly quick, you might want to check your blocks. You may want to recheck your finding. They have chased down the wrong rabbit hole because they usually clear. And how do you know when they clear? The upper fossa test will now right now your legs are perfectly even. The blocking is gating the effect of. Now, if you had first rib tenderness, I could kind of monitor that and see if it was. Now I'm going to go back to this upper fossa. It's still cooking. So when it's cooked, that test will go weak. That strong indicator muscle will go weak. So we wait. Like I say, no more than 2 minutes. They never take that long. They take more than 30 seconds, maybe a minute. Then you want to check your blocks, check your findings. Sometimes they're just not going to move with the blocks, and I'll just say, okay, enough's enough, and I put them on their side.
So when you were testing for the fossa, her arm was weak and it's showing strong now because of what?
Blocks are negating that.
Okay.
Yeah. Yeah. She's still cooking. Now, in my office, I have a percussor. I have a couple of percussors, and I will often, I'll make sure they're breathing, because I want their body has to accept this correction. Good breathing. Just rock their body a little bit. This helps feed more afferent into the central nervous system so the brain can, they're basically trying to get the brain to reprogram. It already has the right program. It just has to plug it in. Unplug the old program. So I'll sometimes take my percussor, I'll put it on the bottom of their foot. This is kind of fun, on the bare foot, and I'll say, tell me when you feel it up here. And then tell me when you feel it here. And then I know that percussion has loosened. Somebody had a percussor. No? Somebody said I had a percussor.
He has an active.
Oh, that thing, yeah. Wonder if the school has a percussor.
We used to, but.
They're really cool. I could bring mine. It's kind of heavy, but that will a lot of times speed up the. There it goes. Now I'm going to take the blocks out, and Dr. Francis always said take the blocks out at the same time. That way you're not jostling the newly adjusted pelvis. So then you re-examine. Is the leg? It doesn't at all appear to be short now. That doesn't show now in the clear without any block. You can sit up, face that way, and we'll go back to where we went in on this, which was a strong indicator muscle with a positive TL, which doesn't show now, right? I don't know if you feel any different, but. Yeah, so it's not showing. Whatever I did changed those findings. Now go walk around a little bit. Go, just take a little through. She's got, I love her. She's got this thing going.
You making fun of me?
No, not at all. I like, you've got this kind of thing going on. It's really kind of cool. Still not showing, so I'm kind of happy with it. So now, it'd be nice if she would have had some pain or something that we could monitor before. So somebody else, thank you. Somebody else had one. You guys had.
She has a tattoo with a spinal basilar. I have a tattoo.
Okay.
Wrist line up. Yeah, there was a lot. So
Go rock and have a tattoo.
yeah.
You were pretty. You didn't have much going on earlier. Well, let's try you. You might be a fairly simple example. Now, once again, let's look at his posture. We didn't do that. I'm going to. So look straight ahead. So I'm not seeing a whole lot that's very much red flaggish. Go ahead and come out and turn, stand here and see if these guys. And it really, he doesn't really. There's nothing outstanding with his posture. It's pretty normal. anything, he might be a little bit, something going on there, but, okay, have a seat. I want to try to keep it as simple as we can, but when you get into Cat 2s, it's really helpful to test them standing, seated, and supine, because you'll get different, you're challenging different stuff. Do you remember which side it was before?
It was this side.
Left side, left side. So put your hand right over that. Make sure it's a nice, flat, broad. Oh, yeah, right there. Put it on the other side. That's okay. Now, what if he weakened with both? Or what if, then I might take his hand over here and have him put it just randomly up here. Because I'm checking to see, maybe it's his shoulder that's causing it to go weak. But no, it's not. So don't ever hesitate to double check yourself. And it doesn't TL on the right, it only TLs on the left. So that really lets me know that it's a Cat 2, most likely. Lay upon your back, please. So what do I do next?
We're gonna test to see AS or
Is it AS or PI? And how do I do that?
start with leg length.
Leg length and fossa. Now, he may not have a leg length. He doesn't. His leg length is perfectly fine. Yeah, that shows. Now maybe he's just ticklish. Maybe maybe he's sore from a certain workout. No, those don't show. But right here, the upper fossa very, very distinctly shows. Now, is this tender? Yes?
Yeah.
Is this tender? Okay, so that fits. So he's a left UMS, just like our last case. Except your short leg doesn't really, it's really not short. It just doesn't show short. Do you have an anatomical leg? So, hopefully somebody will have an AS. How it looks like. Is that tender? Is that tender?
That's more.
More here?
Yeah.
Okay, interesting. But it's his left PI. So what do we do next? Next step. This is the PI side. What do I do?
Block it.
How? And then the other side, I'm going to block it. 45. Now, how do I know if the blocking is just right? That's not right. It's still testing positive. So maybe I'm too far in. Maybe the block is too much. It might be just barely out. This is how you. That's better. So the block was cranking him too much. Let's see if this, make sure this is. Okay. So you can retest to make sure your blocks are dialed in. Now, after the blocks have sat there a little bit, you can go in just for fun. Like I'd be grabbing my percussor and putting on their foot and maybe asking them a few questions. That's any less tender. Sometimes this is tender. And then this side was kind of tender, huh? Different? Okay, that's right. We'll let him simmer. Now, I check while he's cooking. I check his adrenal. And they're active. They're positive. Now, like I was saying before, the category 2 pelvis has a sort of a signature chronic presentation when there's adrenal dysregulation, adrenal fatigue, adrenal balance. His won't take long to clear because it doesn't. Actually, it's already clear. Okay, we're gonna take these out. And let me have him sit up. Now, there's a lot more pressure on his pelvis and low back in this position than lying, right? So it might clear that way just fine, but now we're gonna really put it to the test. So then push in. Take a strong indicator muscle, TL your left SI. Doesn't show. Doesn't show. Move around. Wiggle it. Touch it again. Take a breath in and breathe out. Doesn't show. Now go take a trot. Go. Give it a little, so now we're challenging the whole kinetic chain on both sides. Have a sit. And then touch your left SI again. Make sure this is coming in. Touch the other side. Sure. Push. Uncover. Now go ahead and put both hands there. And that's good too. I think we'll learn that next session or two. Now, you failed to inhibit on plus, didn't you? Did we ever figure that out? Did you guys ever fix that? Or did I fix
No.
it? Okay. So once again, hands off your position. Come forward about 30 degrees. Yeah, so now he's fine. And I think we did find that the SI was involved.
Yeah, that's how we.
Yeah, that's right. So Plus showed his category 2. And of course, it was still there until now, and now his plus is normal. Yeah, that kind of. Forgot about you guys. You see how that works. Perfect. That's a great example. So, thank you. Oh, these yours?
Yes.
So does anybody have a question at this point while I drink my chai about what we did with these last 2 category 2s? Oh, not at all. You totally got it? Ready to do it on each other? Yes, question.
So if it was the degree that,
No. Well, I would, if, say, for example, he had TL'd, somebody's got to have a AS. You got one?
I think we did it in the first.
Okay. You had it in the first session?
Yeah,
And I adjusted you side posture with that.
yeah, but it didn't stick, and then I tried, I'm on the adrenal complex.
That's right. Which one did it test? Did we test?
What do you mean?
Did we test the adrenal at the last session? Thought we-
Yeah,
Yeah.
you got adrenal complex, so I started taking it.
Oh, the herbal one. Okay.
Yeah.
So you've been taking it.
Mhm.
How much are you taking?
Just one of the caps.
Just one a day.
Mhm.
You have it with you?
I don't.
Well, we had it in the
Tell you
test.
about it, yeah. But she's
Please.
saying she might have
They
Along
didn't
with-
fix the last time,
It didn't
like,
hold.
because of the adrenal
Right.
issue.
I see. Now let's check your posture. Anybody see anything? Concerning? This is a hair.
Say it louder, what do you see?
Speak up. So this shoulder is a little high. Her head is tilted to the right. Little, maybe not. Maybe it's your hair. No, actually, you're not too bad. This shoulder is the high one, and you are right-handed.
Yeah.
Just keep standing. So let's just see if that lat. Yeah, so the lat's weak. Yeah. So the upper trap is height. It's not being balanced by the lat. But that, that could be cat 2, it could be. Have a seat, please. Now I always go to Piriformis because it's so handy, but you don't have to use it. You can use a seated rectus test, which I don't really It's not too bad, chest, but you're moving pelvis. You can use a delt, you can use a neck muscle, chest, you can use all kinds of things. Let's use your CN. Those are good. Upper trap. Turns. This way. No. Yeah, there you go. Oh. That's good. This upper trap. Good. Now let that stretch. Remember what happens with a hypertonic muscle? Chest strong in the clear, and then what? Give it a quick stretch, and it'll temporarily weaken. So that's a hypertonic upper trap. You were trying, right? Strong with a hope. Let it stretch. Stretch in the upper trap again. Hope. Yeah, see that upper trap is tight. That could be why the lat's not firing. But who cares? Does she have a category 2? Right? So touch here. And yes, she seems to. Now, come back here, gather all the information you can, breathe in. Hold your breath. It's negated by an in-breath. That means it's an EX, most likely. It means that it's a normal finding. It may be an AS, it may be an yeah. If it's an PI, EX, that's a normal listing. If it's an AS, IM, that's a normal listing. So, now what do I do next? Look for a short leg. You get different socks.
Yeah.
Wow. Now you got an anatomical. Yeah. So her right leg is short. Is it? That's interesting because it didn't look that short when you're standing. It didn't look like it.
I have a chronic like hip issue, so I don't know if that's why it's always short. But every time I test it, it's short.
Have you ever had X-rays?
Yeah, and you can see.
Are they standing X-rays?
Yeah. See, just one side's higher.
And see that the thing is about X-rays that can be deceiving is
They didn't fix it and then take the X-ray.
right. And if you're standing there with a so on X-ray a PI side will actually show higher. The ilium will be higher because of the effect of the rays. So you'll see it'll look like a high on that side, and it could be interpreted that the other leg is short. In fact,
But Joe, aren't they for anatomical? They're supposed to actually measure your femur, like measure the actual
I
bone.
don't think they've ever done that.
Yeah.
No.
So like if they took the X-ray before and saw that, then they treated you and didn't do an X-ray after, then it's functional.
Okay.
Like usually I think they have to technically measure the full length of each of your bones.
they're rarely going to do that.
To
It's a lot of X-ray.
Yeah, I wouldn't suggest getting more.
So right now, actually, as you're laying there, yeah, that's actually not quite as short as it was. We're going to do the fossa test, right? And it was the left side. Hold there, strong in the air muscle, TMC, right off the ASIS. And there it is, lower fossa, upper fossa, lower fossa. It doesn't show on that side because this is the active side. So this might be that tender.
Really
So
down there a little.
so to right at just bottom edge of the fibular head. Here,
Yeah.
tender, here to here.
No, it's not.
Okay, so that's interesting. So she's got medial knee tenderness. She's got lower fossa and long leg. So she's got kind of a mixed bag. So her adrenal reflexes are active. We've been hitting those pretty consistently with everybody in here. I'm afraid to have anybody check me. Okay, so her Chapman reflexes are active. Then taking the adrenal complex. Can somebody dig that up for me? Would somebody mind?
I think it's already out.
I think he had
It's already
Oh,
out.
that's right. That's right. Thank you. It pays to not. Pays to not put things away. Leave stuff out, it's much better.
That's the only one we don't have.
So I'm gonna ask you, actually, I'm gonna have you sniff. Now, this is really far-fetched, but that negates that finding. Now, it doesn't mean she's fixed, but when a supplement does that, you know you're kind of probably on the right track. Do you have any of that with you?
I don't know.
She's definitely in, this is really weird. You're actually a PI on the left. She's a PI on the left. Now I'm gonna check. That doesn't show. What we just learned, ocular line, your right eye. Eyes open. Eyes open, lift. Up, up. Up to the left. So, did you have your neck adjustment?
No, but we did find a left, like, ocular lock.
So it's the same thing we found her.
Yeah.
Punch didn't fix it. So, yeah, this complicates things, but,
Sorry.
no, that's okay.
Do you think that's why she's switching? Yeah, okay.
I do. So, we know we got a category 2, for sure of that. We did find that the lower fossa tested versus the upper fossa, right? We also have medial knee pain, which will actually TL. We also have lateral knee pain, but it's not where it should be. It should be a little bit higher. She has a long leg on this side, which would go with an AS. This side is the short side, but yet. So when I go back here and I challenge it, this way, nothing. Challenge it in further to PI, it goes weak. So that is a PI ileum.
But then the medicine changed your findings, right?
It changed the fossa finding.
Which
then-
sometimes I find that like the medicine, because you need it, will change what you have. Like the body's interpreting it, so then it'll change your findings.
Right, that's true. Close your right eye. Okay. Now, that's weak in the clear, right? Let's see if, hold there, that's weak. Now close your right eye. That negates the finding. So her cervical, your atlas on the right, most likely, and your C2 on the left, they're part of this whole complex. When I say category 2 comes, it's a package deal. If I test her her long head tricep, that's pretty good. Sometimes that will do weak. That's pretty good. I'm going to do a static challenge on your lower cervicals. And I will often find, category 2 often will find anterior C5 or 6, usually a 5, on the same side as the PI. Now I'm just going to put you in a position here. You had your neck adjusted recently?
Not recently.
Are you comfortable with having it adjusted very lightly? So what I'm going to do first is I'm going to take her hand and I'm going to put it in a position that it reduces that anteriority. The anteriority can't, yeah, please gather round. Now, this looks extreme, but by doing that, her brain goes, oh, that C5 is not anterior now. It's kind of okay. It takes a while for the brain to figure out that there's a bunch of other stuff in it. But just keep your head like that. Good. Open your eyes up this way so she's in line with her head. Close your right eye. Nothing. Eyes to the left. Nothing. Eyes straight up. Nothing. Straight down. So in that position, her brain goes, oh, that's it. Her brain thinks she's adjusted. Yeah, that's how I think of it. Now we go to the upper fossa, lower fossa. Yes. So this kind of clears away the static that was feeding in, was switching. So I have two decisions to make. I have two choices here. I guess that's one decision. I can go ahead and treat her in this position with the blocks and clear the cat 2, and then put her head back on and see. I see right now she's actually more even than she was with her head in neutral. So I could treat the cat 2, or I could adjust her cervicals and then go back and see how much the cat 2 is left. Both ways could work. It's not always clear what way to go, but I think I'm going to treat the pelvis first. Because what? Okay, that shows something there. This is a couple of sessions down the road. Breathe in. Or reset her ICD. I think it's breathe out. All the way up. Breathe, 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 breathe. Push your ICD up towards the opposite shoulder. Try to encourage that valve to kind of wake up and shut. Put some tone in there. Breathe in. And breathe out. There you go. Keep your head in that position. Sorry.
It's okay.
So now I'm ready to treat you for an AS pelvis. Yeah. And I could be wrong. We might do this and it might not work and we might have to rethink. This is actually,
How do we get to A?
it kept throwing me off, and that's why we went to the neck thing. With her neck in this position, it takes a bunch of that out of play, so now the body can kind of tell me, assuming the body's telling me the truth. I didn't mean to get this complicated, but
You're blocking an AS.
blocking an AS, this
On
is
the
the
left.
AS side, and that should negate on the left, and that should negate the lower fossa plane, which it does. We didn't have any ocular lock findings with her head in that position because she has the C5. You can come down here and see what's happening here. She's actually still a little short on the right, which I think is, actually she's shifting. She's shifting. Sometimes you do this little bit of movement like that and it'll help kind of hustle things in. We'll still have to adjust here. You okay?
What's different about the blocks for the AS versus?
Actually, the blocking is the same. If you have an AS, you block it like this. If you have a PI, you block it. Now, in this case, the AS is the active lesions. PI is just, we always block the other side just to support it. If you've got an old building and you're trying to level it, you're going to stick wedges in and you're going to do it until you get all the foundation to come get true. This is a really interesting example. And I run into this all the time, but yeah, she's still cooking. So I would get my percussor out, I'd be kind of playing around, maybe having her deep breathe, maybe have her close her eyes. If we'd already determined there was some emotional involvement, I might be doing those points just to kind of calm her stuff down. You okay? Ask me that.
Just following
You
instructions.
can feel free to tell me if you start not being okay. Do what I'm told. So that's showing again. So I'm taking these out. Now let's see what's left. Doesn't show. Go ahead and TL this left side. Now keep that there, bring your head back. Give it a second, for a nervous system.
You still want me to do it?
So, pull your eyes to the left. That negates it. Very close your left. That negates it. She still has the same. So now I'm going to clear her cervix. Okay?
Yeah.
When's the last time you had any work done?
Maybe
Did I adjust you last session?
during the,
It's like their time to work on each other, practice.
DSD.
another system.
Skills. Yeah,
I'm gonna go with
directed
that.
skills development.
So I'm going to just very gently kind of nudge this C1. Give it a little nudge. They make a lot of noise, but you're moving literally fractions of millimeters. C2, I can be a little more into the C2-3 facet here. There we go. Move nice.
That just scared me.
Okay, so TL that again. Flat hand. Doesn't TL. Didn't have to go back to that, it just doesn't TL. Now if you sit up and, now we could have done the neck first and it might have negated the effects of the cat too, but it would have come back. We could have found it eventually. I felt it was probably better to do the cat. Okay, so. TL. Show, let's go to the other side. Let's go to the other one. Come around, do this kind of like thing with your hand. This is for TL of your ICE. Did that. Sure that. And that's okay too. Okay. Now let's go back. I'm going to use your back Chapman points for your adrenals. I'm just going to wake those up a little bit. Get your hand away. Now we need that there stuff. Yeah. We had it. This doesn't have any smell. It's nice when you can.
Oh, but you could have it chew it.
There's only a few in there, so I don't want to break them apart. Okay, so that's negating. Now this sounds like, this looks like friggin', like old-timey medicine show stuff, right? But it's, those are active. That in her energy field, just kind of even just right there. Don't even. That shows. And come a little bit closer. So right in there, she's in her etheric field, etheric part of the aura. You need those. And you know what? I think you need more than one. How about that?
That's fair.
More. What's that?
She said, how about that? Like, imagine that,
don't
you would
mind
need
me,
more
I
than
want
one.
Connection with standard process, right?
Well, I didn't even take this one, a different one, because I don't remember something mountain Peak adrenal complex.
Oh, okay. So is it similar, like a adaptogenic?
I was hoping so.
Is it SB in the medicinary?
Yeah.
They can order everything
Oh, okay.
if they don't have it on the shelf.
Okay.
No, and that's a very, very way to test, but honestly, I think 4 or 5 a day.
Oh.
Yes. This gets way outside of what's considered, I would go.
Serum processed antibiotics are pretty low dose.
So honestly,
You do have to.
I changed mine to 2 a day.
2 a day. Okay.
2 a day. 2 a day is twice as much as you intake. Yeah. Yes.
I would do 1 in the morning and do 1 at lunch.
Okay.
Then it helps your cortisol for the day.
Mhm.
And then after that.
Thank you.
So, yeah, just check your posture. Do we have any ball? While we're getting paired up, because we're gonna try this, while we're getting paired up, you can go do a little height. Do you see anything? Any difference, any improvement in that? So it's like a little bit. Actually, that's fair, isn't it? It's a little better. Take a hike. Take a hike. Get out there, just really, let's pair up and check each other for potassium. Find a strong indicator muscle and do a 1-hand TL. Nothing more than that. Do that first. So everybody experiences that. I almost stepped on it. Yeah, exactly. So, guys, so here's what I want you to do. Don't do anything else. Do this. Find a strong indicator muscle, have a 1-handed TL. If you get a weakening of the indicator muscle, put them on their back and start doing the, find a strong indicator muscle, if it's a PMC, I prefer to use a PMC because it's, and then check upper fossa, lower fossa. Check for leg length difference, medial, lateral knee tenderness, and first rib tenderness, which you may or may not. Do that on each one of your people only. And if you don't find one, that's fine. And if you get stumped, call one of us over. So don't do anything else until we do that. And then we'll switch. So everybody gets a chance, because I know we're going to find about half of us in here have
I don't know.
This one?
Yeah.
Oh my gosh.
I know. I just started getting really shaky. Okay. Do you need it?
Shopping.
Yeah. It's good. Not bad, right? But we don't know. Yeah.
Okay, ready?
We get to. Oh, yeah.
Yeah. We could go back and do like the clutch stuff and see what happens. If we just want to play a fun game. Would you like to sit down? Yeah. Sure. Okay. Sure. Okay. Let's do your dough. I don't know here. You what? What do you mean?
Use your words.
Oh. Let's see.
I have an apple.
I was thinking checks out. Okay. Do your, can you, tilt your left side?
Take her money too. Okay.
You got it?
Thank you,
Can
girl.
you do your right one? There we go. Okay, so, now lay down.
Oh, God.
So it's your right side. Okay, Is it really?
Oh, yeah, it's like slash. Sorry.
She's not.
Oh, no, I was like, wait, but they only one arm. No, my arm is like. Okay,
Touching you. Just kidding. No, no, that's
okay. So it's your right side, your left side. Okay, so now lay down.
So I don't need to touch it, right?
Do I have to take my shoes off?
No.
Victoria. Alright. One leg is long anatomic. Okay.
What is that? Oh, that's your shoes.
Wait, what's that hurt?
Really? Let's try fun. Okay, so let's do this. Okay, that's fine. Are you laughing at me?
No, I'm just looking at
So
my feet are sweating.
Laughing at a lot of things.
yeah, she'll like make eye contact and then giggle.
She's reading your mind.
Okay, so long.
Did I? Maybe I'm holding yours up.
There can be both, right? So like a cat is free, like you're not.
I would not do that. That's why I was like, I did that. Okay.
Anyway,
Well, I might as well.
no,
I don't know. I think I have a tendency to just like hold it for no reason.
But then when you test it, it's like,
Okay.
No, literally.
Very nice. Very, very nice.
Okay. Let's check your legs. Oh, you can put your arm down. Where are your legs? Are they even?
I'm even.
Wait, am I lying? I can't really. Okay, here we go. Here's your.
It's because you think number one time I did that, you're like,
Wait, so if this is. I don't know. I can't tell. So if it's this side and this should be short. Which one's long?
yeah.
Let me get my shoes.
Maybe it's like.
I'm using your shoes.
I'm using my shoes. I don't know. You just say.
We're actually gonna go.
Elisa. 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 Hello. Hi. So I can find this by just like putting my fingers on your malleoli, right? Why are they? Is that like even to you?
Did you have her bridge? Maybe she needs to clear her.
Okay. Can you do a glute bridge? Down she goes. Like maybe like short, like barely, but I can't feel. Yeah, I need that. Okay. Yeah, go with that. Okay. I think I did all the things. She has all the characteristics of her pasta. Oh wait, I did this one. I think I checked all of it. Okay, then fix it. Fix it, yeah. Yeah, okay. Where is anybody using? Can I use your shoes? My shoes. They're not very No.
here's some shoes, there's some Birks under there.
Will that work? You think you can have? Yeah, okay. I know. He said they'll work.
I use rolled up towels, I use cardboard, folded up, you know.
But it's just the should work.
You can do it like this.
Oh, like upside down? Okay.
And with a sneaker, you're better off to turn it upside down the slide and it's more like a block, as long as there isn't a bunch of dog poop on it.
That's so true. Okay, these are just someone done in
And
the
if
dad
there is,
lab.
they shouldn't be in the room anyway.
Me, come over here. I had it like this. It's okay. Just like safely away from my face. 40, 90. I was thinking. So you're, yeah, I tried 90. Well, I get a little bit confused too with my torso. It's just like my sister's long. Also, I think it's like Dr. Zimmerman always says, high waist pants. You never know where you get. Mine is like this. Yeah. Maybe next quarter. No, I'm the opposite. Even if I it's just like everything is just like.
Which side?
Okay, this in there like this. Lateral lower. Yeah. I'm not crazy. So he said to check to see if he did right. We can, it would be stronger. What's the well, he said to check the block is correct. Oh, should be. Right? Oh, you want to see if it's like in the right place? Yeah. I would. I forgot that. I think it's just still. I don't know why I do that.
You just opened her arm. I was like,
I was looking at what you were doing. I was like, what is being?
all doing it in round.
I think it helps me think. It's weirdly fun. It's fine.
Well, there you go. Yes, ma'am.
Okay. When I okay,
She's strong.
She's as soon as okay. Yeah, that's okay.
And she's got.
Okay, that's
Because it's back.
Sometimes they do
Correct.
it, the muscle.
So we're right. I just didn't understand if I was
You're trying to get.
if it was still
Pressure right.
yeah. Because I was like, is it the same?
Let's see if we found something.
So when she.
It's pretty much right.
So you're gonna be like, when I think about a cat, so yes, quickly cat too.
My bad.
So like, how does a cat work? How does a cat
Well,
oh, I think that's kind of right here. Sorry.
Don't put your eyes take like one
Ready?
What do you think the truck is?
She knows on our end.
I believe that.
Yeah, I know what you're talking about. Really?
Oh, okay.
I thought it was like a trap.
On the trap, you know.
Yeah. Oh, you're talking about like weight up though. Yeah. Thinking from like, okay, it's a sick trick like the yeah. I've got some primary story.
Because I was like, wait, he's but sure, I just
Do you want me to like do it on you so you can
I just also like find out.
helping portion.
I like
And then what kind of relative causes something or it's causing.
Nice. Okay, so yeah, we can just be like, I'll do it on.
That's already that
She can tell you.
it's still tender, but that's out. Now it's already on tender.
I did like push kind of hard.
It could be saying esteem. Maybe. I think it's where's your belly button? So you can't see anything. So is it like right here? It was
Now,
oh, that's what he said.
when you guys.
Yeah.
Oh.
It's one way go off the table. No, what's the weight one?
What?
To see if your adrenals were active before I. Sorry, I don't know why every time I laugh,
I don't know what happened. I didn't know what to apologize.
And then she doesn't say anything, so I'm just like,
Yeah, I don't notice it.
yeah, I didn't check before.
Don't rush it.
Oh, my God. Okay. No, your left.
And then, and you guys.
We did not have to. Darn. Oh, you did literally anywhere. Okay. I think her shoes were too flat. Oh, that makes sense. And I don't have socks on. Okay.
Yeah, you can leave them on there as long as you want. Oh, no, it's okay. I believe it's
So is this like a?
No.
Yeah.
I know. It's like I can't tell.
That's where I had it to begin with. I was like, right there. Yeah, there we go.
So that feels really okay. Then I would have definitely but it was so close. Well, I'm sorry. Yeah, like I had it here, you had it here. I was like,
The middle spot.
I think it's fine.
You think so?
Nope. If it tests out, we'll see.
I don't know. They feel like
Okay.
I don't know.
And I'm not like blocking her correctly.
That's like that's what
They should be 90. What? The PI side?
PI side is 90.
Oh,
This side. Oh, is that PI?
yeah.
Oh yeah, 90. This keeps coming down a little bit. Like greater trochanter of the PI. And go 45.
Oh,
From there. Now test.
No, yeah, we were down there. Yeah, no one knows. Oh my God, here we go.
I almost went down.
Better?
Yeah.
Very nice.
Okay, have fun.
Just rest. Check it after. Can we do it while you're resting? Where is it?
Yeah, so.
Over here. Can we do like this? Does that hurt? Right?
It's just yoga.
He's like,
Yeah,
it needs to go up. Can we do it?
Up or down?
It needs to go this way. So maybe
Check out whichever way.
when I do it, see what happens. See.
That one, try to reduce.
So that's
Hey, I'm
does it actually go in the opposite direction? Like I did. Yeah. Sorry. Right, so it flows. Because he said up this way.
You're hypertonic in the clear, you're hypertonic when you feel.
You could try it food directed by Morris too. Yeah. Oh, wait, hold on. I don't want you sitting here today.
Oh, yeah.
I forgot. So did I. It feels really good.
Yeah, yeah.
On like the open and closed ICUs.
Yeah.
So.
Oh my.
Oh, so that was
Okay,
What's happening here? Oh, okay.
I had it done like this, like 2 weeks, and they're all, and so some of my and it hurts. Right out. I mean, I'm really surprised when I hear like
Okay.
so, but we went to do my ICV.
Or,
Right.
Switch.
Yeah,
I think so.
Yeah.
Yeah.
That way.
That way. Yeah. Okay. If it comes strong this way, it's stuck close in one speed.
Okay, that's right.
Yeah.
So like that way.
This is close. Yes. So you have your battery available. Point should be right up there, right on the anti-X.
So I'm gonna put this.
Yeah, you're having her breathe in on the breath out. You're dropping your feet in first, putting it really far down, and then.
Watch it again.
Oh, it's not forward. Now out. Now push down. Yeah.
Oh, yeah.
You need to just make a different angle.
I asked her the same, and she said she feels okay. I don't know.
Did you feel open up? Sometimes you can.
Well, she's gonna fix it, right?
It's still not. Still close. No,
Nice job. Good job.
how deep do you have yours?
Yeah, that's a good question.
Yeah. What?
So first, I mean, just TL it and see.
You're not testing.
And then.
I have scoliosis, but okay.
No, I think
You have two innocent bystanders here.
So I TL then you find out what direction the gates, in your case, up.
She's a cat reading.
She kind of looks like an egg.
So that's gonna close it.
Yeah, her left.
So, yeah.
Towards your shoulder.
Do we not do that?
Okay, okay, back.
No, because it was obvious.
Is that? That's about how we.
She looks twisted to me.
Breathe out.
Like this.
That's how you.
It's like a combo.
It's a combo, see?
And then you can go back.
Yeah.
So it doesn't show.
Lay down now. Face up.
That's about how. You know how, you can tell her how deep.
My back actually.
Strong shoulders.
Yeah, okay.
I want it.
You're also.
Yeah.
Not a lot. Just a little
I mean, I'm in people, I just test that for you. So, and then you feel like she goes, okay.
Okay. Find a strong muscle. Find a strong muscle.
Sometimes it would kind of struggle when you lift your hand. How it wrestles at you. It's always,
He was so fast.
it's always.
Oh, yeah.
Yeah, so find a strong indicator muscle.
Did you guys both get to be
Well, you fixed mine. What do you want to check?
We have blood cells all over right now. Do you want to check that?
Oh, right.
Yeah.
Oh, nice.
Yes.
No, I just fixed it. I was like, oh, I guess I don't have any work to do.
Huh?
Yeah.
Me or her?
You. I remember that. Yes.
Okay, I'll try it again.
All right. I'm glad we figured that out. What?
She's maybe like, yeah, she did.
Did I? I do stuff that I don't even realize.
No, okay. You just walked in text with me saying, like, you're doing this right. No. Oh, they said that I heard giggles. I was like, what are you talking about? I was like, you came in. I didn't even know I was doing that. That's why I was like, what are you talking about? That's so weird. I didn't know like that.
Okay.
You actually got a curl. Got a fold out. Curl. Oh, you, like, can you
Bend it?
you still go like this? Whereas you gotta like this? Sit like a cashew. Yeah. Oh,
Like a cashew.
That's so hot.
Yes.
I can tell.
Okay, what hot body person?
So, yeah.
Oh, nope, still fine.
Why are you constantly laughing at me today?
Am I? Like, hold over again. You take that off. Yes, I'm gonna be hot. It is.
I was like sweating earlier.
Okay. I don't lie. That was great. Okay. I got
This is
We all know.
Okay,
where are you gonna, which side do you
no, I do feel like that's hot. Okay. Yeah, I
Okay.
okay, no. Something I think is still there. Something. Oh, it's supposed to be off.
See if it works.
Maybe that's right. Well, let's figure out how we're gonna do this. Because I was like,
Just want a good time.
my brain.
You block set.
Aaron, I'm gonna go to the bathroom.
Because if you got.
You gonna go bathroom? Yeah. Okay.
It won't be.
Because you can still tee all this side, but
Okay.
the pelvis is off either way, it just like.
So.
So we can tee all this side. Notably low, really low. This one's like 2 fingers lower. So we don't
Why is it so small?
now it's over here to like.
I know. That's what.
I've always been. Yeah, and we normally have that.
What? Sorry, I'm not paying attention.
The blocks are the same.
This is the long way.
No,
than
it
what we
should
do.
be strong, right?
Yes, because it was weak before
I
you had the
always
block.
wear my toes.
You got the long way. This one.
So, I thought I
It's.
have.
We're working on it.
Yeah, we're working on it. So
You
there's.
can use this piece.
Yeah, that's.
I was like, me?
It's okay.
I'm gonna order it.
Everybody's.
You're right.
No, but I do this.
You guys still doing cat too? Oh, yeah.
No, Dr.
Okay, let's test it and see if she's done.
Oh, yeah. Yeah, she's
It's
like a whole way to need to
Then you have.
supposed to be.
Right?
Oh. So you don't do that?
I would do it, yeah, because she got a lot. I would
That was our indicator.
see if your blocks are done.
Are you done?
Yeah, ask her for blocks. Test her with the faucet. And then if she clears, then take, walks out, and then go back and test her. Yeah, because you don't want to test it yet.
Everything is getting hypertonic.
Really?
Hyper you. She's very.
Well, check to see if her faucet tests. The upper and lower faucet. See if her upper faucet should weaken.
That's cool.
Which is that wow.
There you go.
Now I gotta use the bathroom.
I don't accept, right? I don't accept occupation before she was like, oh yeah, I know.
It's crazy.
That's what she was telling me.
You're what? Asleep. That's the only thing about like afternoon caffeine is that you're sleeping for like 2 minutes and then you're like, never mind.
Now,
That's so fun. I remember seeing like something.
I would check it close your right eye.
Also, look at how much.
Yeah, there's just like,
I know they put sand in here, but like the drinks guys.
a lot of
Probably.
And then we have the scale, right, so we scale this, so checking that off.
So, remember how to do your irredeemable?
I said irredeemable.
Oh, you can, but that was. And then once in my life.
So here's what you do, you come in
Did
here
say.
I was finding earlier with like.
Why?
Do you need some water? Will that help?
So then I would say, get this around.
just about through.
And then just look at me. Anything else?
Knock that cranial out, and that will normalize a lot of it.
Oh,
You guys are
let's check
supposed
it.
You do it.
Do you want us to check it? Just kidding.
Because initially I was really, because I really.
We were supposed to take the cranial.
Oh.
It's not. The word is called it. No. The next time. Oh. What is it called? Why am I thinking right now? C. Cruciate.
There's one last thing. She's doing a cranial and she should be done, cooked. So who all had a category 2? Anybody not have a category 2? You didn't have.
Got category 1.
How'd you fix category 1? We haven't done that.
We didn't.
You'll have to hang on to that for a moment. So almost everybody had a cat 2. How many cleared? All of them? Everyone's cleared. You guys should be top 1. Did you get yours?
Yeah. We should live another day.
As long as everyone
It's like a.
So can we get through, I want to get through this adrenal blood sugar thing. Kind of get through these slides. This is important, of course, very important. The slides are kind of boring. A lot of this stuff you probably know. Those of you who are kind of late stage in your training have probably been exposed to quite a bit of this understanding. This is, some of this, when AK started getting popular in the 70s and they started teaching this. I mean, treating adrenal problems was, nobody did it. It was like a brand new thing. It was a huge thing. So some of these slides seem a little maybe dated because it's like, you're like, well, yeah, duh. You know, Poncellier, nobody had heard of him until AK started, you know, bringing all this information to light about adrenal. Hans Sallier is the guy that wrote The Stress of Life, I think in the 50s, was it? He did all kinds of research on adrenal fatigue. And just to think, all of our mankind's history, nobody really looked at adrenals until maybe maybe a couple, 3 generations ago. So anyway, adrenal blood sugar, I throw it all together because, you know, I don't think it's necessarily fair to lump the adrenal, to say the adrenal glands are stress glands. It's a little misleading because they're the glands that give us the ability to rise to the occasion. It isn't just stress. It's, we run up a flight of stairs, we need a little shot of epinephrine so that our blood pressure doesn't suddenly drop and, you know, pass out. And that's not really an emergency or a stress. It's just, I guess, a physiological stress. But when we run up a flight of stairs, the body doesn't have a chance to warm up and gear up and vasodilate and bring all the things it needs to make sure everybody's getting the oxygen and glucose it needs. It's like a temporary override. So the sympathetic parasympathetic system is there to protect us. But if we overuse it, its regulation can get out of step. The same with the cortex, which is really like 2 different glands. So the glucocorticoids are the ones like corticosterone, cortisol, that kind of thing, and then the mineral corticoids are the ones that, like aldosterone, which is very much involved in blood pressure regulation or body water regulation. Aldosterone facilitates the kidneys reclaiming water at the distal tubules. And if our aldosterone is low, we can be drinking all the water we think we need, but our body isn't hanging on. So the kidneys are charged with taking all these toxins and diluting them and breaking them down, and it takes whatever water it doesn't need and puts it back in the blood. How the body keeps, it's one of the ways the body recycles things. But aldosterone is what facilitates that. If aldosterone becomes low, then we get dehydrated, and we can be drinking gallons. I have a lot of patients that kind of, drink all this water, but they're clearly suffering from dehydration. It's because their adrenals are really wacky, and they're channeling all of their pregnenolone into cortisol and some of these other hormones, and there isn't enough left over to make. So this is probably a review for you guys. Epinephrine, norepinephrine these drugs are super powerful. They are basically neurochemical transducers. So they directly affect the sympathetic nervous system. The other hormones from the cortex are more. Epinephrine and norepinephrine are what target the beta cells on the heart. So when people's blood pressure is going up, and it's determined that the beta cells are reacting. The medical physician is like, well, too much stress, and so we'll block some of these beta cells. That way, the epinephrine can't have its effect, so the heart can't react to stress the way it normally would. It's a very short-sighted approach to blood pressure, but it does kind of work. Metoprolol, which I'm sure that's a really common beta blocker. I see people on these people who are really out of it, and everybody's trying to get off of it. But lisinopril, which is a really common one you see your patients on, is a it's a ACE inhibitor. So it is the one that interferes. It will cause your aldosterone to get even lower. It will actually interfere with the function of aldosterone. So the body's attempt to recycle and hang on to water is further hampered with these drugs. And they're prescribed every day. This is what medicine uses on. And I see people that come in, they're on 2, 3 blood pressure medications. Their blood pressure is just barely kind of hanging there. Like nobody's and everybody and their doctors are just fine with it. Well, yeah, we got your blood pressure under control. And they feel like crap. They're dizzy. They can't digest their food, but their blood pressure is under control. So this is what you'll run into, guarantee, if you haven't already. I'm sure you have in the clinic. Of course, the alternative is much more complicated. Functional hypoadrenia is when the adrenals just start to lose. First, they lose their ability to kind of. First, they hyper-secrete. And we can stay in hypersecretion, hyperadrenia mode for decades sometimes. It depends on how strong our adrenals are. And then they start to fail. Like any gland, they'll start to fail. That's when we go into adrenal failure. Most of you young guys are probably struggling with just dysregulation of your adrenals at this point. So they're kind of overworking, and then they kind of have to rest, and so they're not showing up for a few days very well, and then they kind of, you got finals next week, 2 weeks. Yeah. So right now you're going to be getting your money's worth out of your. So anyway, this is all the things that come out of the cortex. Different parts of it. This cortex is actually a multi-layered system. Catecholamines are what come. That's the epinephrine artery. I think Dr. Whitney mentioned this earlier. So if you guys, I got a slide on this. Slide here. So I know I do. There's a really cool one that shows you how this stuff is distributed, and I think. So this is Hans Cellier's work. We've got, at first we can stay here for years, and then at some point our adrenal glands adapt. They up their production. They get bigger and thicker, and at some point they've had enough. Same thing happened with the thyroid.
I find thyroid follows adrenal dysfunction.
Yes.
So a lot of times people show up with thyroid, if their labs will be off, and some thyroid symptoms, but if you treat the adrenals, the thyroid catches back up and they don't actually have a thyroid issue.
It's absolutely true, because it's kind of like, if you think of the thyroid as the idle setting in your engine. And it should keep a nice idle when you come up to a stop sign. Well, if the thyroid is low, a lot of times you're overusing adrenal. Hit your accelerator to kind of keep your engine running until you get down the road. That's kind of, and then other times, like excess cortisol and excess estrogen will dampen the function of the thyroid too. So it works both directions. All these things can be, all these common presentations of patients can be, of course, they can be all kinds of things, but this is all the things that people show up with when adrenals are involved. One of the biggies is what's going on? I don't know what's going on. Help me out there. Tech people. Anyway, so while I'm looking for that slide, so the adrenal glands make pregnenolone from cholesterol, and it's one of the things I've learned about over the years is a lot of times when people's cholesterol, when their LDLs are going up, a lot of times that's because their body, as was explained to me years ago, it's because their demand for cholesterol goes up and they need quick deliveries to create adrenal stress hormones. Low density lipids are often, they're considered like the bad cholesterol, a problem, but the body is doing that because it needs to, it can move low density lipoproteins a lot easier than it can. This is the body. So when somebody has high LDLs, they can dream it. Why is their body demanding all these LDLs? Because it's used, the body's using these LDLs. It's using it to make all kinds of stuff. We make vitamin D from cholesterol. We make CoQ10 is made from cholesterol. So pregnenolone is very expensive, physiologically speaking, to make by the body. It's a complicated, takes a lot of energy to create this stuff. So it's kind of limited in its production. So you have just so much of this base material to make cortisol, estrogen, testosterone, progesterone, corticosterone, aldosterone. All these things have to be made from this one base material. So body has pretty strict priorities. So if it's constantly shifting production to cortisol, you're gonna be shifting production away from productive hormones and away from the mineral corticosteroids. So anyway, back up.
I think you're clicking too fast
Is that it?
because they all have that transition.
Yeah, I've been trying to get rid of that. That was in there.
So like it's like you have to like click it and then click it again and wait for it to pop.
Can you find the one that shows all the different?
Oh, yeah.
It shows pregnenolone and all that stuff. So you guys have heard of pregnenolone steel. Familiar with that term? You know, when I was in school, we didn't talk about this stuff. We didn't talk about adrenals at all. There was, and still in medicine, you won't find really anybody that speaks adrenal. They speak thyroid because they have a lab test for it. It's like they didn't speak anything about nutrients until they had a test for vitamin D. All of a sudden now vitamin D is important. It's always been important, but they never had a blood test for it. They have a blood test for vitamin B12 now. So all of a sudden that's important. But nothing else is important. Adrenals aren't important because there's no way to monitor it, except if you use things like free-fraction blood tests, which I don't even know if you can do those anymore, and salivary tests, 24-hour salivary tests. Do you guys use
You
these?
can get like an AM cortisol by itself. That would be like a free cortisol. Or the cell.
It's not free-fraction, is it? It's free-fraction.
I don't know. It's usually, I just do the AM cortisol. That's enough.
The salivary, I used to do the salivary test all the time. They were really fun. And then they got kind of expensive. And then I got to where I didn't do them anymore. But you find some very interesting things with these. People take salivary samples throughout the day. And then I think it's 4 or 6 different, 5. And then you send it in and they come up with this cortisol profile. And the first time I had it done, I was in the freaking tank. I was like all morning, I was barely bumping along, then I had some spikes. And eventually I got that better. I had patients who, they were flatlined until about 7, 8 o'clock in the evening, then they'd have a spike, and then they'd kind of do this, and they couldn't sleep. These are the people that can't sleep. I had a lady, she's still a patient, this was 20 years ago. She still works nights. She's a respiratory therapist. She works graveyard. That's what she likes. And so I had her do a cortisol salivary test throughout her normal shift. She has lunch at 3 a.m. or 2 a.m. or something like that. Anyway, her salivary cortisol profile was completely normal, except it was a mirror image of what a person who works in the daytime, which was interesting. So those tests are really valuable. I don't know what they cost these days. They used to be about $110.
150.
150, oh, so that's not too bad. I think the information is really worthwhile. Diagnostics is, oh, here we are.
They tell you, what did I use? Dutch will tell you that you should run the saliva and the urine. Figure out what the cortisol, cortisone is, because they'll do both to see if you're converting to cortisol.
Who's that?
Dutch test, but they don't put those together as an option, which I don't know why, but that's how they say you should get most accurate testing. That would run you.
I
like,
heard of them. I might have to get that info. Anyway, this is, here's cholesterol, and this shows some of the key nutrients. This comes out of Dr. Wally Schmidt's work. So when you're testing, like we tested Dean on a variety of things there, we could have taken it further and tested him on, look, we got niacin here all over the place. Pantothenic acid, there's B6 is in there somewhere, I think. Vitamin E, really key to, getting testosterone to convert. Anyway, these are nutrients you can kind of have in mind. There's a lot more than this. There's chromium, or there's, well, copper is really important for the epinephrine. Steve Ganjami, one of our ICAK diplomates, he teaches a bunch of stuff. His website, he has some really good charts that he's made. And he's got charts for and he's got all the nutrients involved, like very thorough. I think he did a really good job with it. You can get those to the ICAK. He's got, they're kind of like this chart, only they're smaller, so you can have don't take as much space, but I highly recommend them. I can't remember what he charges. They aren't cheap, $50 a piece or something. But anyway, so that's what to think about with, people are taking cholesterol-lowering medications, these medications that interfere with the body's production of cholesterol. So you're automatically interfering with the body's production of vitamin D, CoQ10, all of your adrenal cortex hormones. So it's when you stand back and look at it, it's completely ridiculous. Think about it, but that's what people are doing. So they're obsessed with cholesterol. Still, I have a Kaiser doctor I see once in a while because she orders my blood work. She's very nice. She has no clue about any of this stuff. I try to talk to her, and she can hardly get out of the equipment. She lets me just order whatever I want, because I always want extra thyroid. And she just fine, yeah, sure. And she's very nice about it. But she had the nerve last time I was in there, just getting a regular checkup, to suggest I go on the statin. My cholesterol is 200. My cholesterol is perfect. It's that of a 20-year-old. Didn't used to be. It used to be worse. And I'm like, why would I go on that? Well, you're an old white guy, and they're all on cholesterol. And it's like she had no reason other than that her perspective is that statins are preventative. They're like a preventative measure.
Or you reach a certain age, and then that's the list of medications you're supposed to be on.
I'm on no medications. I've been with her about 6 years, and she just still doesn't. There's something wrong. I'm just not on any medication. When I first started with her, I said I have a mild case of Hashimoto's. I diagnosed it like 15 years ago at that point. And she, whoa, wait a minute, what? I said, what are you on? I said, I'm on selenium. I rotate iodine. I'm off gluten. That's how I got my thyroid to normalize it. It just made no sense for her. I said, wait, you mean you're not on any? So finally, we just let it drop. But she has no clue about this shit. And so they should, but they don't. And my nephew is a pediatrician. He asked me one time, he's a brilliant kid, wonderful young man, great doctor. He's been getting adjusted since he was this big by me. He asked me one time, he was just getting out of medical school. He said, now what is the difference between homeopathy and naturopathy? And I didn't even know where to start. He just wasn't sure what the difference was. Anyway, so we're all the victim of our.
I think the biggest thing is just ask why. Stay curious. Why is the cholesterol high? Why else does this matter? Right? or whatever your findings are. Just keep asking why until you find an answer. Because there's always a reason. The body doesn't do anything by
I mean, there
accident.
are occasionally people who, doesn't matter what you do, their cholesterol can be high, but
Sure, but they know that.
Kind of
It's usually like familial
yeah.
or something.
And that, those people are out there, but they're much. So, anyway, this is the medulla hormones, and these are the nutrients you want to think about. Once again, there's niacin again, B6. There's the copper. Yeah. Anyway, methyl donors, you need B12. The MTHFR thing, if you're not processing your B12 properly, or that, then you could potentially affect your epinephrine production. Anyway, that's it's really slow, isn't it? Wheat germ oil, choline. This is the book that Wally wrote in the 80s, believe it or not. It's still a really pertinent book. If you go for diplomate and AK, you need to know this book. You need to know all this stuff in this book. Trust me, you need to. Unless they throw a whole bunch of questions out. But,
No, that is.
you need to know everything in the blue book. You need to know this book, and you need to know, there's a couple others. This was a book Dr. Kim used to recommend on sleep disorders, adrenals, sugar, blood sugar, things like that. I read a book a couple years ago I highly recommend called Why We Sleep. It's written by a sleep researcher. I can't remember his name, but it's fascinating. If you ever want to get it. And Wally has a lot of really good stuff on his website about treating people with sleep disorders. He does a lot of work with eye movement. He was a neuro doc. Okay, so I wanted to mention, so we keep talking about adrenals and how do you determine if somebody's adrenals are wacky? Well, one, of course, is a Chapman reflex. Another is a weak sartorius gracilis. Those are red flags. Ligament stretch. Somebody had it. Dean, did you have it? Did you come forth? Or anybody else who thinks they have ligament stretch syndrome? This
Everyone
is
who had a cat too.
what's that?
Everyone who had a cat too.
Everyone had a cat too. You got a cat too. You had that lipic. Let's see if that's still there. Oh yeah. I always go to the deltoid because it's so handy. But I'm just going to challenge your first rib there. Challenge this C7. I adjusted a C7 T1 first rib. That's still out on him a little while ago. So he still has a C. He has a C6 actually. Challenging it left to right, and he said, breathe in and hold it. So I'm just going to clear that real quick so it doesn't muddle up my other tests. Breathe in. Now, if someone had this technique I'm going to show you here in a second, breathe in. Okay. I'm just kind of riding around with that C6 and making sure it kind of finds its way into its track. Breathe in again. There we go. That's just a respiratory correction. Hold there again. Good. So that's good. Okay, so it's called ligament stretch syndrome. And you'll see this with people who have adrenal dysregulation. Let's go to this on. You can take on this a little bit. Now, I could take any ligament area in the body. I'm going to take a shoulder and stress it that way. You get a weak muscle. Now, it's temporary because we didn't do anything to the shoulder, of course. I could go in here and I could stretch his lumbars. It doesn't matter. I mean, I could take his neck and just give it a little stretch this way. Anything that kind of stretches and stresses the fascia. See, he blows out everywhere. That's not somebody you want to start yanking on. I adjusted you yesterday. I adjusted you today. I probably should have done that respiratorily. Gave him the full velocity. Going over.
Just spin it until it works.
These people, when they have this, will often not hold adjustments well. So when you find this, and it's so easy to screen for, hold there. You can take any ligament in the body. Spine. Now, what was it you strengthened on?
5.
5.
Should looked up. I'm already taken 35 HTB.
Well, yeah, you're taking the
After
drink.
yesterday, I don't think I'm taking anything, so.
So I'm gonna sacrifice one of these.
Oh, yummy.
I know, I had no idea what you were doing.
Yeah, I got a feeling.
Can't taste worse than that.
So go ahead and, now let that kind of coat your tongue. What we're wanting to do is wake up the receptors so the brain knows this stuff is
Sure,
there.
I had to drink.
Okay.
Yeah, it's lovely. It's like chocolate and flowers
Nice.
after they're dead.
So I'm just gonna go through and I'm gonna do. Now, the bizarre thing is that this will negate if you get the right nutrient in real time, which is still surprising because supposedly this has to do with the adrenochrome effects on ligament, on the myofascial matrix. But it will negate in real time, and I keep trying to prove myself wrong, but to prove that doesn't work, but it does work. So, I mean, that negated, that just erased his ligament stretch finding. You have water? Something besides that drink. Get some regular water. Drink some regular water, wash your tongue off, and give it a minute, and we'll retest and see if it's on that. Because we didn't give him enough of that to do any real. That water. So there's water in it somewhere.
He starts hiding this monster in the water. Like a real actor.
I have patients, I said, how much
was-
water?
That was actually kind of gross.
I'll ask patients, do you drink water? Well, no, not really. If I drink a lot of coffee, like,
You have to put water in coffee to make
there's
it
a lot of water, it's mostly water. I'm like, okay.
About 3 liters a day, 2.5 to 3 liters a day of just water. Rinse out the kidneys, you know.
It is like crystallized.
So it's off his screen. It's down off the screen. There it is. So this guy needs he needs adrenal support. He happened to test on 5 HTP, so that's. But yeah, adrenal support, because if I start yanking on him a lot, he's not going to hold his adjustments too well, because you can see what happens when I just challenge him. That's ligament stretch syndrome, or the ligament stretch test. And it takes how long to do? I mean, I did a bunch of different tests, but you could do it with a couple of stretches. It takes seconds to do, and it'll tell you right then and there, oh, better use respiratory, maybe, just long lever stretching, work on the muscles, maybe do any cranials, anything but a high velocity adjustment. Don't ask him to do like extreme stretches or anything for out. So anyway, thank you. That's you're welcome. DHA seems to be the ticket. What's the ticket?
A ticket.
This is something if you guys can handle like layering another. This is kind of fun to test for if you're really, especially if you want to really sell somebody on the fact that they are stressed out. If they don't believe you, and then you can test an adrenal-related muscle. Sartorius is a great example. And you can have them bilaterally TL both SI joints. Now the problem with that is if they have a category 1, that's going to show a category 1. Better if you have to fix that first. Then you go back and that one clears all the different findings, then you can. But this is like ligament stretch technique to determine if they're Success syndrome. Anyway, I don't want to get. When you find it, test them against the adrenal support of your choice. Actually test them against as many as you have time. Oh, here's ligament stretch syndrome. So this is the mechanism supposedly behind ligament stretch. Adrenochrome, adrenoleutin causes a breakdown of ligaments and causes them to have less integrity and less strength. Now that all makes sense, but why does it strengthen and
Well, it's just telling the body that that's what it needs to regulate the cortisol.
right? I get that, but it's like, what's the mechanism? Because it's purely energetic when you're testing. And I'm open to suggestions, but it does work. I use it all the time, but I don't always. So much of the stress our patients are under is their own doing, but you're not going to tell them that right off the bat. But it isn't entirely the stress that comes at them, it's how they respond to it. Most people are still hanging on to the effects of the stress from a week or a year, 10 years ago, and then the new stress just keeps re-triggering the old stuff. That's where things like NET, and because you can find those connections with the old triggers and often disarm them. That can have a profound effect on how their body is physiologically responding to stress. It's like that glass bowl thing. You're fine as long as the glass still has room for more water, and finally that last drop comes in, and you get water all over the place. So, eating right, gosh, you guys know about this than 99.9% of the world, but sugar is an enormous problem, and we're just not done with it. Just when we think maybe societal awareness has kind of caught up, some new abuse. I mean, I can't believe how much people drink nowadays. It's like amazing. It's like binge excessive drinking seems to be kind of normal. I just, yeah. So, but 150 pounds roughly, I've heard 170, I've heard all kinds of different, but it seems to be somewhere 150, 175 pounds per year per capita in this country alone. Now, 100 years ago, or say 120 years ago at the turn of the last century, we consumed 7 pounds a year per person per capita. That's an enormous difference. So no time, you go back 120 years, and all of our existence on Earth before that, however long you believe that was, we had almost no sugar. So the islets of Langerhans is about that big on the tank. It's the only place in the body where we secrete insulin. It doesn't appear to me like it was ever designed to handle huge amounts of sugar. It was kind of there for when you might have stumbled into a beehive, caveman. Maybe you had a little too much root, boiled root or something. There was just never a need for huge blood sugar management measures in our bodies until the last 100 or so years. So, I mean, overlooking this, I mean, this is just enormous. It's just a huge part of what's causing people to be sick nowadays. Not just sick, but dysregulated and neurotic and everything else. It's a huge problem. I've seen absolute miracles when people go sugar. Way more miracles than I've ever seen with any supplement or herb or adjustment or anything. All of that's important. So anyway, all of you have probably had your experience where you've gone through a fast, or you've done a detox, or you've done low glycemic. I mean, we've all probably done that. Right? Experience it. If you haven't, do it. If you tell patients not to eat sugar, you better be prepared to relate to what they're doing, because it's difficult. They usually go back on it. They'll go off it for days, weeks, months, feel amazing, can't believe, life-changing, and then they slowly go back on it. So they're right back at 150 pounds a year. So I don't need to go into too much. You guys understand this stuff, right? You can teach me this. This is, and you know, we've all had, I got in late Friday evening and I didn't eat hardly all day Friday, just was too busy. And I ended up just famished. I ended up eating like a teenager Friday evening. And when I was done, I was just like, oh my God, what was that? My blood sugar finally came back up and I was like, oh, okay. I was in trouble. And I don't let myself get like that too often, but I did. Anyway, these are all things, low blood sugar. Everybody is hip to this nowadays. My mother read a book it came out in 1970, a book called Sugar Blues. And it was a huge, huge hit in the 70s. People reading this book, and this guy wrote this book about the dangers of sugar. It was like it was a brand new thing. Nobody even thought of that before. How could sugar do your health? This book, and a lot of it was kind of funky of the time, nutrition thinking, a lot of it was kind of funky. But this guy had gone off sugar, and it completely changed his life. And he lost a whole bunch of weight, and he got healthy again. And this was 50-some years ago. That book's still in print. You can still find it. Anyway, we digest carbs in the mouth and in the small intestine. They're kind of just in the way in the stomach. So there's a really good there's a really good argument for being careful with your food. You guys all know. Bread and meat together, which is what's more mainstream than that. The carbs dampen the digestive fire. So if people are sleepy after they eat a sandwich, well, test them for gluten, one. But also say, well, why don't you try just eating the meat, and then an hour later eat the bread. Let's try that. And a lot of people will do that. And it can make a huge difference on how they digest and how they feel after they eat. If they're getting sleepy after they eat, there's something wrong. Something wrong with what they're eating, and something wrong with how their body is doing it. Krebs cycle, you guys all know that probably by now, by heart, right? All the different stages of the Krebs cycle. Dan Jemmy has a beautiful chart on that, where he shows every nutrient you can test for that's involved in every one of those stations on the Krebs cycle. Maybe the club could look into it. He'd probably give the club a deal on some of his charts. You better. We should.
He's the president now.
He's the president of ICK. Anyway, yeah, I think right now he's got some of the best charts going. Anyway, these are herbal adaptogens. One of my favorite products by Biotics is ADHS. I use it on myself for years. It's a fantastic product. But there's no glandulars in it. It's also a really good B complex. It has all the proper B6s and B12s and all that. And it has the adaptogenic for it. It's a brilliant product. It tests really well. Glandulars, I love. I don't know how you guys feel about glandulars. Anybody in here taking glandulars? Everyone? Pretty much everybody, except those who haven't. You haven't? There's different. I know people who would never touch it. Vegans. If I test them on a glandular, they're like, "What's in that?" I'll read it up. They just press. So I try to find something else they can take. And I promised them that it comes from like calves from New Zealand and all that kind of stuff, but it doesn't matter. This is all wacky. So Daniel yesterday talked about inositol. That's a really good thing to test on your patient. Inositol is in the B vitamin thing somehow. B6, magnesium, B3, zinc,
They call it B8,
B8, vitamin B8.
structurally similar.
Okay. So, I mean, in a perfect world, get them off sugar, test them for dairy, gluten, soy, corn, nightshades, nuts. Oh, the biggest problem is when I get people to quit eating gluten, they start eating more nuts. And I've done that too. I love nuts. But a lot of, I mean, nuts are really problematic because of the all the little structural proteins, nuts, and the peanuts, which I love. Peanuts have a lot of mold, fungal residue on them. They're a Lego. They're kind of like soy. So if somebody's sensitive to soy, they often are sensitive to peanuts, short of having an anaphylactic reaction. They just don't do well. Even though nuts are very nutritious and they have the right kind of oils and all that, too much. Our ancestors would spend all morning getting that many nuts, you know, and probably have to hike miles to get at them. Now you can go to Costco and you can get a thing of peanuts and you can just grab handfuls at a time. And that's too much. They don't digest well. I think it does. I think a lot of the vitamins and stuff get broken down when you're soaking them.
Yeah.
I think it makes a difference. Yeah, almonds. I love almonds, but I don't digest them real well. So and we soak them, and they're crunchy and yummy, but they're just intolerant. Anyway, we have 50 minutes. I introduced a whole bunch of stuff. We covered a lot of it. We workshopped pretty much everything I want. What do you guys want to do in the last 50 minutes? Want to review the muscles? Do you want me to take a couple people and see if I can fix some stuff? Want to turn on some music? Dancing. I mean, I would be happy to maybe go through a couple protocols, maybe stuff that we've learned this session and maybe some last session, and just show you how I think when I'm seeing somebody. That'd be fun. So stepping away from all the focus on the stuff, anybody in here have a headache? What kind of headache? Is it one-sided? Is it deep? Is it top? Is it back here?
Yeah, mine starts at the back, goes forward, and then down my jaw.
Yours?
Mine is like mainly in the back, and then it kind of like go to the top of my head. Go, you go.
No, well, wait. Now, does anybody in here have a low back issue? Like low back? You? That's right. You and knees. Oh. Knees? Knees. Injured knees or just knees? OA. OA.
Oh, no.
Osteoarthritis. Oh, okay. X-ray, confirmed, and the whole bit. Maybe low back. You take a look at that. Because this is kind of in the real world. Like tomorrow morning, somebody's going to come in and have low back pain. They're not going to come in and say, "I got a category 2 and an ICD," and they're afraid of it. They say my low back hurts. I don't know why. So let's start with. Let me have you come over here.
You will be fine. You can't.
Had you guys down at the end of the last session.
Just take it.
Okay, so does anybody want to take a guess at what posture tells us? I'm not seeing any no major red flags. Your low back hurts right here.
It's like localized in my sacrum.
Okay.
Like where can I sleep?
Have you had what has anybody found on you today and yesterday?
I had a cat 1 and
Okay. Cat 1,
We didn't do anything with it.
Cat 2, did the Cat 2 get fixed? So, can you walk for us a little bit? Can you just, can you walk, maybe,
Do you want them
I
to
want
watch
to,
me?
I want you to, I want to watch you walk. Maybe just back and forth there, see? Or maybe from side to side, from leaning over. See if we can pick up some information. Just walk like nobody's watching. Okay, so just walk. Let's go out here, guys.
I knew it was gonna come to this.
I had to. I had to. You said that. You did that right. I used to do it all the time.
Yeah, you know, you're still kind of very aggravated. Okay, so let's just, let's have you lay on your back. So this would be kind of a typical thing. And I'm gonna throw in some stuff that we haven't done in this class yet. Don't ask me too many questions. I'm just gonna show you what I'm doing. Yeah. So I got her in this position. Range of motion. Ooh, that's a little tight. Dr. Wally was big on, look at that. The difference. He was big on, see that? That's, and this one right here, she's over 90 before we get any feel. Abduction. Not too bad. Abduction. Greater. Like degrees greater. So she's freer on the left side. Which side was it? Your crease was moving that way and this arm was doing more. Now remember the forward arm, the more forward arm in gait, goes with the stronger psoas on the opposite side. Likewise, the less arm swing, the contralateral psoas will be weak. So let's just test your psoas. Hold there. There. Push up. Breathe in. Just for later. I mean, maybe that's. Breathe in. Okay, so that the breath doesn't negate that. Breathe all the way out. Yeah. So both psoas muscles are not firing yet. Sit on the end here facing this way. I want to kind of keep the stuff in both hands. Now we're going to test what? Rectus abdominalis. I push straight back or I do push this way? Straight back. Not so much. Okay. This way. Straight back. Not so much. Okay, breathe in. Hold your breath. So respiration isn't playing a big role. Breathe in. Hold your breath. So that's just not, is that painful? Where? Okay. Right. So now I'd be very tempted to just put her face down and start really looking at the local thing here. Is that tender here? Here? Anything tender here? All of it?
Yeah.
All of it?
Yeah.
Like the sinuses are tender. Go ahead and stand here facing that way. And I want you to do a basic squat slowly. I know you guys were doing this yesterday. Now just show me how your squat is. That's not too bad. Now come back up. Now go ahead and go into a forward bend. Bend your knees a little bit. You don't have to keep them straight. And just let yourself relax. Now, is that painful at all?
It just feels like a stretch. There's no pain.
It's just tight, okay? We come back up. Or pain when you come up. So we know that our abdominals and our psoas muscles aren't showing up. So they're not helped. Typically, when we go into forward bend, the muscles in the front of the body pull the body into forward. And if they're not firing well, then we're basically using gravity to sort of lower ourselves down with these already overworked. So I'm going to see what we can do to turn on the psoas muscles in those. Bend your back, please. So I'm going to jump to another mode here. Push, push. I'm going to test your acupuncture pulse points. So liver gallbladder always seems to show up first. That's okay. Side here. So liver gallbladder, is it the more superficial? Is it the deeper? Seems like. Okay, I'm going to test her for switching or for just general K27. Shouldn't weaken there. If I do this and quick flip clarity, that's normal. That's normal. That's pretty normal. There's other little tricky things you can do. You can kind of sweep her reception vessel and make sure it's running the right way. So you think of the meridians, especially the central meridians, as being these lines of things in the body, but really the meridians clear out. You know, it's a whole matrix of the chakras. You can hold there. I mean, I'm getting way esoteric. I push. You can kind of do up and kind of swim in the. Just sometimes that'll see if they're. I see right there. She kind of weakens. So that's the kind of stuff I might do. In addition, we know the issue. Now, what's the liver-related muscle? We're going to one this section and one last.
Is it rhomboid?
Rhomboid, yeah. Please sit up. And what else?
Oh, shoot, sorry.
From session 1.
What section of the back? Clavicular? No, sternum. Okay. Clavicular stomach? Yes. Okay.
So pec, major sternal, and rhomboid. So since we just run rhomboid yesterday, bring your shoulder back. Now what do I do with your head? Bring that back. I'm going to pull you around the left. Bring your elbow in tight. That's not a great one. Might have got lucky here. See my positioning? I come straight into her side. This hand is the hand I use to test her. That's not so great. That's better. Now, what do I want to see if? What do I want to use to see if I can strengthen that rhomboid? Here's my choices. I can try breath in to see if there's a cranial involvement. I can go to the alarm point, which we haven't learned yet, which is right there. That's the alarm point. There's also the Chapman, which is also pretty much right there.
You go back to the acupuncture.
You go back to the acupuncture. I know it's positive, but I want to see how that dysfunction is manifesting its way out. What's that?
Did you do the innervation, like the?
I certainly could, yeah. Neck.
Neck.
Keep it simple. Yeah, let's start with that. Go ahead and touch your neck. We want to be Goes to C5-6, make sure you're maybe over here accessing this, where the actual nerve roots come out. Usually when I test a meridian, that's definitely better. I'll go to this point. I usually go to the alarm point. I find the associated muscle, and then I go to the alarm point. Now that doesn't seem to make too much difference. That doesn't do it. So so far the neck seems like a promising place to go. Yes.
I think it was last time we take the class that you said, well, usually when there's a bilateral weakness in a muscle, like both sides go more axial first, so like check
Go
the middle.
central, yeah. And when there's like a bilateral, and rhomboids, that's usually upper thoracic. It's kind of like, we don't talk about that so much, but like definitely middle trap, lower trap, definitely.
That's still true.
It's a central fixation. It could be that, but we're going to have to clean up her neck first. Have you had your neck work on today?
No. I mean, you tested it before and I had bilateral.
We didn't adjust.
No.
Okay. So, like I say, this is kind of this is how it would be in my office, just on a normal understanding. To start. So that, when I think cervical, lower cervical, see both of those are. Stand up again for me. And let's try these lats. Yeah, so that's already, so her neck really is a major factor here. Bring me back. It's sort of, now I'm feeling for, now she had bilateral tricep weakness unless lat weakness unless we put her in more of a neutral neck position. She was kind of flexed. Breathe in. Let it go. Let your body stretch. Breathe in again. Let it go. I'm just stretching. Ooh, there we go. Breathe in once more. So just turn your head. I'm just going to kind of clean this up a little bit. I'm coming in through just a P to A, nudge there. Nothing real hard. Okay? Mm-hmm. And then this one's a little more stuck too. You can see my vector here. There we go. There we go. Mm-hmm. Those look really brutal, I know. Okay.
Yeah.
Okay. Sit up again, please. Now, she TL'd the neck and the rhomboid turned on. So, pull. Better. And pull back. Good. Now, sit here, face that way. And once again, let's see how we're doing with this. Yeah, big difference, just from the neck. So, but we haven't helped her back yet, maybe. Stand and face that way. Now, I want you to go into forward. Is that any different?
A little bit more.
Let your head relax. Let your head dangle.
Oh, it's a little bit more pain.
And through here.
They still look like that.
Okay. Okay. Now come back up. Lay back. And the hands to your body, side of your body. These were weak. Now they're turned back on. All we've done is adjust your neck. Get back on. I want you to, we're going to go back and double check we adjusted the lower circles as the upper neck median. And see, she's grimacing. Why is she grimacing? Is she hurting? It's hard, but I'll test really live. I need to grimace. Right? And I'm going to test harder. Now she's trying not to grimace. Okay. Close your right eye. Your left eye. what's that telling me?
Right eye, straight drop.
C1 on the right, probably. Right eye closed. Eye straight to the left. That's on the left. To the right. That's pretty good. So straight to the left. Straight ahead, close the right eye. See, we haven't adjusted our upper neck yet. No, we have that. Now, take this hand and do that. TL. This is what we call enhanced TL. Another kind of enhanced TL is like this or like this. You aren't just touching like this or one hand, you're adding more energetic connection. So take that. And it's like it's not like a fist, it's like a closed hand. Tips out. Bring this over here. It's crazy, but this doesn't work as well as this. I've tried it. Okay, so what am I testing? Those of you who took it last year.
I see.
Okay, so what do I do next? Those of you who took it.
Find the vector.
Find the vector. So I assume the ICV is an issue from that. Now, it could be something else. Maybe that way to determine is I'm going to go in and push the ICV up, and I'm going to push it down and see which way negates the weakness. Okay. So me just coming in here like this is like her TLing it, and that's weak. Now I'm going to push up, and it turns back off. I'm going to push down like I'm pulling that valve down this way. She stays weak. She stays weak there. She goes strong. So where am I going to correct? Now, we'll learn all about ICV. Is that tender? Still tender? Is that tender? Is that tender? Still tender?
Not as this foot
Sure.
was.
Okay, there. Tender? More than this one? Interesting. Usually it's kidney 4, bladder 58. Sometimes it's kidney 4 and bladder 58 on the same side. Is that tender?
That's worse than.
You guys remember this from last year, those who. This is the Chapman reflex. I promise you guys who are new, you're going to.
I got a massage and she's like.
This is going to be extra tender when there's an ICV. An open ICV, you'll have on the right side, you'll have a very tender bicipital groove. So I usually kind of milk that out, and then I'll actually treat this point. I'll just hold it. In your case, it's going to usually it's opposite side. This helps balance out the meridian part of it. Let's have you go back to its, and make sure that it doesn't TL the way it's fine now. Now, these had turned back on, push. Good. And that's pretty good, but that one's not quite as good as this one. Can you TL your left side? You said you had a cat too earlier, and you fixed it and one. Still have a cat too, or maybe it came back. So, does she have a PI or an AS? If anything, I'd say this is a fraction short on the left. She TL'd on the left. What do next?
Sure.
Upper fossa? Upper fossa. And this isn't a pressure, it's almost like an electrical connection. It's like a really light. So that's positive. but both of the users. And short, so the UMS. Now, TL that for me again. Just trying to stay with our protocol. Breathe in. Hold your breath. Okay. But it's a PIEX. Now, we'll go ahead and block you. We're going to block that again.
Blocks are. Oh, thanks, Steve.
So how am I going to block her? She has a left PI on the left,
90 on the left.
straight in, and 45 degrees. Should I leave them in there a long time? Less than 2 minutes. Now, the cat ones are much more forgiving. If you have the cat ones when the patient, we treat the cat ones, that twisted ones. Cat one we treat prone, and it's. So, do I think I have the blocks right? Do I know I have the blocks right? I don't think I have the blocks right. So that's pretty good. Yeah, so dial in your blocks. It can make a huge difference. If they're not clearing, check your blocks. Now, while she's cooking there, I want to see if this leg is starting to, lengthen out. We did check for rib tenderness. Is that tender? Is that tender? That's tender. So that might give us something to work with. Probably have other stuff up there. Right? How long ago? Somebody else got in a wreck since we were last year. You did.
Yeah.
She smiles.
Yeah.
So I'm going to monitor that for whatever it's worth and see. And I'm going to kind of rock her on the blocks and see if we can get her to speed up her. It can be very unrewarding sometimes if they're. That's good. I go by the indicators. I really don't go by temp very much. Still cooking. So we'll just let you cook. Sometimes I'll grab my iPad. I do my chart. I'll be charting my iPad. I'll grab my iPad and I'll kind of maybe do some charting or something. Or I'll ask them how their whatever is going. Golf game. How's your? Which I really could care less. But how's your kids? How's your dogs? That I find that's much more interesting. How'd your elk hunting go this year? I often like to, because if I ask them about their elk hunting, a lot of times they'll bring me an elk steak. How's that halibut fishing you're doing up there in Alaska? There we go. That's clear. I love really good halibut. Every once in a while somebody shows up with
I said I miss good fish.
Yeah. Are you from Alaska?
I'm from Washington.
Where?
Seattle is a area.
Really? Okay. So is Nicole.
She's from Bigfoot.
Yeah, that's great. You're from the same tribe. Northwesterners. Did you grow up there?
Yeah, I'm born
So Seattle, or you said?
Issaquah.
Okay, so kind of east.
Yeah.
Carnation?
No, I was like Bellevue Sequoia.
Bellevue, yeah. I used to teach in Bellevue. Years ago, I used to teach AK at Bellevue University. I ran a classroom there, and I had a lot of Bastyr students back then. So. What's that?
That's where I got my AA. My associate.
From Bellevue? Yeah. Okay, so that's cleared. TL for me. Actually, sit down. So she came in with back pain, so I better do something about her back pain or she may not come back. Didn't hear about all this other stuff unless her back pain is better. Go ahead and stand and go over and go forward. Okay, put your head down. No? Still tight. You may have to just break down and adjust your low back. Lay face down.
Would you want to do a stretch response?
That's a very good suggestion. Yes, I would. We can do it. Right. Nice work. Those are intact muscles, right? Here's our piriformis pushing. They might not have been before we did all this cat 2 stuff. Those are pretty good. Now, let's come back. Now, we TL here, right? TL here again. See if we didn't TL her in prone, we just TL'd her. And that's holding. I'll go over here, trying to just be over the SI. Now, right over the sacrum proper, up onto your lumbars. Now, let's get really specific. Now, I could go straight to challenge at this point. Got a small enough area there I could go in and just start statically and dynamically challenging. Let's see if there's, yeah, so she comes up a vertebrae or two, and that's not, go push hard. TLing can lapse over into challenge really easy. If you push too hard, you're no longer just TLing, you are challenging the skin, and you're challenging any structures that might be tender, but we know this is tender on here. So I'm going to go right in here. I'm going to challenge her sacral base. I got lucky. You get lucky because you kind of know where to look. You've already TL'd down to a certain area. So it's the right sacral base. I'm going to go up to L5. I'm going to go P to A. Nothing fancy there. Same thing. We go up to L4, 5. Now, and go to L4, 5 on the other side. And go to L5, S1 on the other side. So, sacral base on the right and L5, S1. That's where my correction needs to be. So I could put her on her left side and just do a classic diversified adjustment, but because we don't know if her adrenals, almost we lost our indicator. The good one happened here. That's back. Let's use this one. Push, push. So I could stretch any ligament. I could go in here and just give her ankle a stretch, making sure it isn't injured. And look at that. Okay, so I could make her knee stretch. Good. Make sure you get your baseline back. There it is. I could go here and let's just I'll stretch an arm like that. Same thing. It's global weakness temporarily with any ligament. It doesn't matter where I test it. Now, one could ask, what about your challenge? Isn't that like a ligament stretch? And it kind of is. If they ask me that, I have a hard time explaining the difference, but sometimes you just have to. So, do I want to high velocity adjust her? Probably not. Do I want to see if she has an adrenal issue before I do anything else? I think since I have her here and I know where I'm going to address, I'm going to do a respiratory correction. If find out what phase of respiration we need to correct on. So breathe in deep and hold your breath. That negates it. We're going to go up to the L5. Breathe in deep, hold your breath. Yeah, so respiratory correction in breath, in the direction of challenge, phase of respiration at the gate of the challenge. Breathe in, let it go. And breathe in. I might do this 4 or 5 times. This bypasses what would happen is if I did a high velocity adjustment, because this isn't going to bring the ligament stretch reaction so much. Again. With respiratory, if you really pay attention and you do a lot of them, you'll start to feel when they go. It's always nice with regular adjusting, you know you got it. Breathe in again. But with respiratory, if you really read the subtle, breathe in, good. Give me 2 more just like that. And once more. So, push. Now, so I don't have to go to all the work of challenging again. Let's just have you TL there. It's easier on all of us. And it doesn't TL. Let's go through the high. That's pretty good. So I'm pretty happy with it. There's still something going on. I think she has a little fixation. Got a fixation. Breathe in again. I'm just going to kind of mobilize this. She's really tight. This area, as you can tell, it's now push, 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 push. Yeah, again. So we'll kind of leave it at that. Now, before we get her out of this position, what muscles support the pelvis and the lower big time? Glute max, piriformis, hamstrings. And we already know the hamstrings are functioning pretty well. Remember session 1. What am I testing? That right there. Make sure they can hold it on their own. You stabilize here before there. You take your hand away and then you do the test. Hold. Try that again. You weren't ready, right? Those glute maxes are not showing up. Not in that part of the range of motion. It doesn't matter what else I do here. If those muscles aren't firing well, by the time you get to your car, what we did will largely be. Now she can hold that. I'm going to stabilize here, and then I'm going to test. Ain't nothing happening there. Nobody home. Okay, let's try your piriformis. Now those were stronger earlier, but now everybody's like, now TL there again. I want to see if we missed something here. Still weak. See if this holds. She's TLing her lumbars. And go ahead to the sacrum. Okay, go up, clear up in the ear. You doing okay? Hard work. Okay, so we got to go higher than lumbar. And where's the innervation for the? It's from the lumbar. So let's come up here again. So just stay there.
Oh, been here?
So come up. There you go. There. Now we'll learn this later when we get into fixations. Another common cause of bilateral glute max weakness is upper cervical stuff, which you've already had cleared, right? Mm-hmm. But we didn't really adjust it. We adjusted your lower cervix. Now I'm going to put some pressure on her C2. Bring this up again. That does nothing. I'm going to put some pressure on her C1, just kind of pushing it up. The difference. Bring this up. Sorry. Okay. If I don't adjust her C1, none of the rest of this is going to. So can we adjust your C1? So we had, what have we done so far? Let's redo. We checked your posture, we watched your walk. That's a little bit of stuff going on with walking. We know that you're uncomfortable in forward bend, though your range of motion is very good. She had asymmetrical hip range of motion. This side was much more flexible than this. Let's see if that's changed at all. Way better. That probably cleared up with the cat too. Abduction. Yeah, that's pretty good. So we've made some progress. Now, I'm going to check the psoas again. We had these turned on. Now close one eye. Close one eye. So that blows her out. Close one eye. Up the other eye. Open your eyes. I could do that anywhere in the body. Right there. Bilateral PNC. Close one eye. The other eye. Close. So that indicates what? C1. And I'm going to put my, unless you can reach over there and touch that. That one is, yeah. So we get a positive TL, we had a positive eye open sign. We had a positive effect with the glucac. So we've got 3 reasons now to adjust your C1. We've got 3 reasons to adjust. We don't know with our vector yet. The straight lateral. We challenge it straight lateral. You're a weightlifter person. You don't not like to be weak. It's like, yeah. So I'm gonna go behind and kind of do a little bit of lateral, but a little bit of PA on the right side. That shows, but not quite as clean. Now I'm gonna go just straight PA on the right. That's pretty good. Now lateral. That's really okay. So breathe in. So I'm going to do a respiratory correction on her lateral mass of her, or on her atlas, contacting her lateral mass. And she's going to breathe in deep.
Wait, hold on. Which way are you going? Sorry.
Going this way. Kind of going to go this way.
Oh, okay.
But I'm not going to do anything sudden. I'm just going to find where it wants to. See, right there, it's kind of stuck. Move around until it feels like that vertebrae is right there. Now, I'm going to take my left hand behind her head. I'm going to traction. You can feel traction. Breathe in. For the first breath or two, I'm kind of feeling my way, just like a cranial. Like I'm kind of looking more, I'm listening more than I'm talking as far as what my. Then I kind of dial in to see if I can feel glide. So I'm going to very gently nudge this atlas from the right side. I'm going to do a little bit of a, that's just a little nudge there, and then I'm going to bring you over this way, and I'm going to bring this over. Okay, there we got it. There we go. Okay. Open your eyes. Close your eyes. So that's not showing. Touch the show. How did you get there? Blue max, yes, thank you. Lay face down. I knew there was something major we had to go back to. I think glute maxes. I mean, we get all excited about psoas muscles and all these big players, but glute max is so, so important. Now we'll come back here and make sure the hammies are still good. Push. Fine. See if these guys, they were kind of freaking out, but they're doing well now. Push. Good. Bring this up here. Hold there. Stabilize. You got it? Hold there. Big difference. I'm not faking it. That is seriously better. Hold there. And that's seriously not. So you got one, but not the other. When that happens, because we did have a bilateral weakness and it did TL to C1, I think we did the right thing, but I need to look directly at the glute max. And we'll start down here. Can you reach down here? Remember, with your anatomical education, you learned that the glute max inserts clear down deep into that femur. Let's see if we can. There. Up, up, up. Up, up. There. Not there. Let's come up again. Up. There. Arm okay? Come up again. There it is. Okay, so there's something in there. And I think it's going to be, sorry, I've got to poke around in your glute here, but I think we're going to find a trigger point. Feel anything? Oh, there it is.